It is not easy to be a pioneer, but, oh, it is fascinating, wrote Elizabeth Blackwell. Picture Geneva, New York, 1847. A dean hands a woman's application to a lecture hall full of men as a joke. The students are told to vote. Everyone expects a unanimous no. The ballot comes back yes. Okay. And a door that had been nailed shut opens just enough for one determined person to step through. Elizabeth Blackwell did not chase medicine for glory. A dying friend told her that being examined by a woman would have spared her humiliation. Blackwell took that pain like a prescription. Become a physician not to be first, but to make sure no woman would have to ask for permission to be seen with dignity. From the first day at Geneva Medical College, she is a spectacle. Some professors ask her to sit apart. Some patients refuse her presence. She studies anyway. In the clinic, while caring for an infant with a severe eye infection, pus splashes into her eye. The infection blinds her on that side and ends her dream of becoming a surgeon. Most people would turn back. She changes direction and widens the road. 1849, Elizabeth Blackwell earns her MD, the first woman in America to do it. Then she goes to work on the real problem. One diploma cracks a door. Institutions keep it open. Here is the first big idea she leaves us. Excellence beats prejudice when it builds institutions. In 1857, with her sister Emily Blackwell and Dr. Marie Zakrzewska, she founds the New York Infirmary for Indigent Women and Children, a working hospital where women physicians treat the poorest patients with the highest standards. This is not a symbolic protest. It is a ledger full of recoveries. In 1868, she opens the Women's Medical College of the New York Infirmary, a pipeline from classroom to ward, where women learn anatomy, hygiene, and bedside skill from physicians who expect mastery. Her lesson is simple: be first, then build. Crash the gate if you must, but install hinges on your way in. Second idea: reform medical education by uniting science, hygiene, ethics, and hands-on practice. Blackwell calls it pure preventive medicine. Cleanliness is not only moral, it is clinical. Air, water, light, sanitation, these are as real as scalpels. She insists students learn in the ward, not just the lecture hall. During the Civil War, when chaos floods field hospitals, she helps organize nursing and pushes for sanitary standards that save lives before germ theory is everyday language. For her, medicine stands on three legs: knowledge, skill, and character. If anyone weakens, the patient falls. Third idea: use parallel institutions to force integration and then insist on coeducation. Blackwell does not build a separate world to live there forever. She builds it to prove competence so thoroughly that coeducation becomes undeniable. After establishing a base in New York, she moves to England, registers as a physician, supports the founding of the London School of Medicine for Women. She teaches hygiene in public health and argues that medicine needs both sexes and all classes because bodies are universal, even when opportunities are not. Her endgame is not a pink corner of the profession. It is a profession widened to match the human beings it serves. So how do these ideas work now, where you live? Start where prejudice runs on inertia. Build undeniable examples. If your field keeps recycling the same gatekeepers, don't just argue with them, stage a demonstration. Create a pilot clinic, a lab, a fellowship where results, not resumes, decide the future. Track outcomes. Publish them. Invite skeptics to see the data. Blackwell didn't win with speeches alone. She won with rosters, rotations, and a hospital schedule pinned to a wall. Change how we train. Too many programs still reward test scores over touch, theory over practice, and prestige over service. Ask the question she asked. Where is the ward? Where is the neighborhood? Pair every lecture with a lived rotation. Teach dignity as a clinical skill. Make hygiene, communication, cultural humility, and bias training as non-negotiable as pharmacology. Evaluate not only what a clinician knows, but what a patient experiences. Design systems that make inclusion the path of least resistance. Blackwell's institutions created paths: admissions that recognize talent, rotations with real responsibility, policies that made excellence visible. Today, that looks like transparent selection rubrics, mentorship that ends in placement, pay equity audits, and clinics that publish patient outcomes by equity metrics. You don't change a culture with posters, you change it with defaults. Let's run a quick what if. What if every medical school adopted a Blackwell year? In the first year, half your time is spent in the neighborhoods your hospital serves. Home visits with nurses, mapping asthma hotspots, staffing school health fairs, learning how housing codes show up in blood pressure. In the second year, you rotate through community-run clinics co-led by nurse practitioners and physicians, where you practice listening before ordering tests and learn to write plans in plain language a patient can summarize back to you. By graduation, you can culture bacterium, organize a block to fight a mold infestation. You can interpret an EKG and read a lease agreement. You understand health not just as lab values, but as a lived environment. What if every teaching hospital had a Blackwell ward, a unit staffed at least 50% by clinicians from underrepresented backgrounds? Rounds that require the patient to summarize the plan in their own words. Hygiene and compassion scored as hard metrics. Leadership chosen as much for mentoring as for publishing. Imagine how quickly adherence and outcomes change when respect is a protocol, not a personality trait. Blackwell's story isn't tidy. She argued fiercely with allies and opponents. She broke with friends over strategy. She was skeptical of fads and wary of money distorting medicine. She could be severe mostly with herself, but read her memoir, pioneer work in opening the medical profession to women. And you hear the same note again and again. Build well or don't build at all. She wasn't chasing applause. She was pouring foundations. Listen for the quiet details history almost forgets. The lodging houses that finally rented her a room after others refused. The anatomy professor who let her stand at the table because the dissection would not wait for culture to catch up. The clinic nights when her sister Emily kept charts, while Elizabeth soothed a coughing child whose echo carried 2 blocks down the street. The patients who told their neighbors, "Go to the women's hospital." They listen. And the best part? The day woman doctor became simply doctor because the institution she built made it ordinary. Here's the carry home. Be excellent, not to appease a critic, but to anchor a new standard. Build institutions that make the door you walked through wider. Tie knowledge to service, hygiene to humanity, admission to ability. When parallel systems have proved their point, merge them so the profession reflects the people it serves. If this story moved you, act while it's warm. Mentor someone the gatekeepers overlooked. Fund a clinic that teaches by serving. If you run a program, measure compassion like a core competency. And if no one will give you a place to do the work, do what Elizabeth Blackwell did. Make one. Make it excellent. Then make it standard. If you want more deep dives into the people who changed how we learn, heal, and lead, subscribe. Share this with someone in medicine or education. And tell me in the comments. Who held a door open for you and how will you hold it for someone else?